Hi everyone, welcome back to Next Level Ophthalmology. Today we are starting a new chapter on Retina. So we will be including the first class on Vitreous. I would like to begin the class by paying respects to Dr. S.S. Badrinath, founder of Shankar Netralaya, who was a pioneer in retinal surgeries in India. So the topic will be divided into 4 small topics: relevant anatomy, embryology, disorders of the vitreous and surgeries of vitreous. So vitreous in Latin means glass. So vitreous is called so because it is optically clear. It is a gel-like structure that occupies the posterior segment and is responsible for maintaining the structure of the eyeball. The volume is around 4 ml and it has a refractive index of 1.33. It is biochemically made of type 2 collagen interspersed with hyaluronic acid. The vitreous gel, vitreous is a gel that occupies the posterior segment of the eyeball. Which of the following is false about vitreous? It is hydrophilic. This is true because it contains so much of hyaluronic acid, it has to be hydrophilic. It is responsible for determining the intraocular pressure. This is false because vitreous is not a dynamic structure whereas aqueous is. So any drop or increase in the aqueous volume determines the IOP, not the vitreous. It is composed of hyaluronic acid, true. It tends to liquefy with age, true. So the right answer here is B. So let's move on to the parts of vitreous. The vitreous is attached to the retina at something called as the vitreous base, which is present straddling the ora serrata 2 mm ahead and 2 mm behind the ora serrata. Then there is a Vigert's ligament, which is a circular, if you take the cross section, it's a circular taut ligament between the anterior hyaloid face and the posterior capsule of the lens. Whereas Burgess space is a very small space that is present anterior to the hyaloid membrane and posterior to the posterior capsule of the lens. The patellar fossa is a 9 mm circular space that is present here that holds the lens. Space of Martigiani is a potential canal in the embryonic stage which houses the hyaloid artery, and Cloquet canal is a potential canal that closes with age and it houses the hyaloid artery which supplies the lens. So a little bit about the embryology we will deal in the subsequent slides. Hyaloid membrane is the outermost condensation of the vitreous and divided into anterior and posterior hyaloid membrane. The anterior hyaloid membrane extends 1.5 mm anterior to the ora circumferentially. Then vitreous can be divided into cortical and core vitreous. Cortical vitreous is the outer layer of the vitreous that is in contact with the retina posteriorly and the lens anteriorly. It is the metabolic center and contains hyalucytes. Core vitreous is the one which is present in the center of the vitreous, and it is the fibers here are a bit looser than in the cortical vitreous. So attachments of vitreous: anteriorly it is attached at the base, which we discussed, and posteriorly it is strongly adherent to the optic disc, blood vessels and the macula. So embryology of vitreous. When the eye develops, there is entry of the hyaloid artery through the optic stalk, which enters through the region of optic nerve and then supplies the lens. So this is known as the primary vitreous, which is mesenchymal in origin and is full of blood vessels. Slowly with time, there is regression of the hyaloid artery by apoptosis, and it's replaced by a gel-like vitreous, secondary vitreous, which is secreted by the surrounding neurosensory retina. Okay, so primary vitreous is mesenchymal in origin and secondary vitreous is what is present in adults. So some people might ask you, what is tertiary vitreous? Tertiary vitreous is represented by the zonules of the lens. A 2-year-old boy presented with spontaneous vitreous hemorrhage in one eye. B-scan confirmed vitreous hemorrhage without any retinal attachment. After 2 weeks, the hemorrhage resolved. and fundus examination shows a blood vessel arising from the center of the disc and floating into the vitreous cavity. So here we are talking about something known as persistent fetal vasculature, earlier known as persistent hyperplastic primary vitreous. So this name is not very commonly used now. We prefer to use persistent fetal vasculature. So the mode of inheritance is usually sporadic. It's usually unilateral. Whenever you get a bilateral case, you should think of some syndromes like trisomy 22 and Norris disease. So what is the spectrum of this? All of the following are ocular associations of PHPV except microphthalmos. It's a poorly developed eye, so microphthalmos is a very common association. Megalocornea, no. Congenital glaucoma, yes. There is a very high chance of the AC being shallow and developing congenital glaucoma. Tractional detachment is also very common. So the right answer here is megalocornea. So let's look at the clinical features of PHPV or PFV. We can broadly divide them into anterior and posterior. Anterior PHPV is characterized by congenital cataract. Mittendorf dot is a dot that is present on the posterior capsule, which is the remnant of the hyaloid artery. There can be a retrolental membrane. There can be long ciliary processes, and there is congenital glaucoma. Posterior PFV consists of Birch-Mister's papilla that is seen as an elevation on the optic disc. It's a benign condition. There can be retinal folds and tractional retinal detachment. So here's a video taken by a smartphone. So if you can see the white dot there, that represents the Mittendorf dot. Yeah, the white dot here, that is more anteriorly, and it is on the posterior surface of the lens. Alright. So a 12-year-old boy presents with a peripheral retinal tear. Fundus shows vitreous membranes in the periphery and narrow sheathed vessels with pigmented spots. Select the syndrome that has eye, ear and joint involvement among the following. So here we are talking about a vitreoretinal degeneration, which is known as Stickler syndrome. So whenever there is associated joint involvement, we refer it to as Wagner-Stickler syndrome. Okay, it is a autosomal dominant, rare, very rare bilateral disease in which the vitreous just liquefies, and the vitreous is described as optically empty. It's characterized by peripheral retinal degeneration with narrow sheathed vessels and pigments. There is pathological myopia with the development of a presenile cataract, and they are predisposed to developing retinal tears and detachment. So these are the images in which you have condensed membranes in the periphery, sheathed vessels, pigment clumps, narrowing of arteries. The next vitreoretinal degeneration is Goldman-Favre syndrome, which looks a bit like retinitis pigmentosa, but there is associated central retinoschisis along with vitreous liquefaction. It is an autosomal recessive bilateral condition which presents with bilateral progressive loss of vision. So let's move on to vitreous opacity. Most common vitreous opacity is muscae volitantis, which is a physiological floater. Okay, whenever there are opacities in the vitreous, the patients presents to us with floaters. Muscae volitantis is a common physiological finding which normalize and more commonly seen in myopic eyes. Whenever there is a posterior vitreous detachment, the vitreous that is attached around the optic disc, it gets detached due to age or trauma. The patient perceives a circular shadow which they often describe as a cobweb that moves with the direction of the eye. So on examination, when you see, we see a ring right in front of the optic nerve, and we call it as Weiss's ring. So posterior vitreous detachment is a benign condition and it doesn't need any treatment. The next cause of vitreous opacity is inflammatory exudates that is seen in vitritis. Vitritis is not an independent condition. It may be secondary to pars planitis, it is secondary to retinitis or retinal vasculitis. So the next common cause of vitreous opacity is tumor cells, which is usually associated with a tumor that is present in the retina, which is exuding tumor cells within the vitreous. More common and benign vitreous opacity is asteroid hyalosis, where you see white opacities within the vitreous. It's an innocuous condition, and these are stuck in the vitreous. There is no liquefaction. Okay, so these are usually seen in eyes with old age or previous history of trauma. Whereas synchiasis scintillans is a more dramatic condition in which you see a golden shower of opacities within the liquefied vitreous. So whenever the eye moves up and down, these opacities move up and down like a shower of golden rain. Okay, so synchiasis means shrinkage and collapse of vitreous, whereas syneresis means just liquefaction of vitreous. Synchiasis is a more advanced condition in which the liquefied vitreous collapses. The next rare condition is amyloidosis, in which you see whitish fibrillar vitreous opacities within the vitreous, and these are seen on the posterior lens capsule. Important condition in the vitreous hemorrhage. It is bleeding into the vitreous cavity. Usually patients present with sudden painless loss of vision, which may be preceded by a history of floaters. These are the very common causes of vitreous hemorrhage. PDR, retinal vascular occlusions leading to proliferative retinopathy, traumatic tears and dialysis, peripheral retinal neovascularization due to a number of causes like occlusive vasculitis or Eales disease or sickle cell disease, retinal vasculitis, head injury, hypertension and papilledema, rare cause of vitreous hemorrhage. So there is something called Terson syndrome, where you get intracranial hemorrhage along with a vitreous or subhyaloid hemorrhage. So this is known as Terson syndrome. So this is how a vitreous hemorrhage looks. So let's take a question now. A 56-year-old diabetic patient presents with sudden loss of vision in his left eye. So there is sudden painless loss of vision. On examination, pupils are brisk. There is no RAPD. There are multiple fronds of new vessels seen on the optic disc and along the superior-temporal vascular arcade with macular edema in the right eye. Okay, so right eye there is proliferative diabetic retinopathy. In the left eye, the retinal glow is very poor because of some problem and you are not able to see. So what is the expected diagnosis in the left eye? So here we are talking about a diabetic patient who presents with sudden painless loss of vision and there is no pupillary abnormality. So the right answer here is vitreous hemorrhage. So if there is a retinal detachment or any of these three options, you will get an RAPD and the retinal glow is poor because of the hemorrhage. So how do you treat? You can wait and watch. Sometimes it resolves, or it can form an ochre membrane that is usually present behind the lens and affect the view of the retina. Ghost cell glaucoma is when these degenerated red cells enter the anterior chamber. That's why it's more common in aphakics, and they go and clog the trabecular meshwork. Tractional retinal detachment when there is a fibrovascular component along with the vitreous hemorrhage. So if it's an uncomplicated vitreous hemorrhage, if there is no tractional band, you can wait and ask the patient to give a good amount of rest and the vitreous hemorrhage settles down, especially in trauma. Once the medium is cleared, look for the source of bleed and treat it with laser or whatever is needed. So when do you do an urgent vitrectomy? When the other eye is blind, when there is associated retinal detachment in this eye and there is loss of vision in the other eye due to the same cause. And you do a vitrectomy, you plan for a vitrectomy when the hemorrhage doesn't resolve even after 3 months. So what are the vitreous surgeries? Surgical removal of the vitreous is known as vitrectomy. So there are 3 types based on how much of what part of the vitreous you are removing. Anterior vitrectomy is usually done during a cataract surgery when there is a complication in the form of a PCR or a posterior capsular rent. It refers to removal of only the anterior part of the vitreous that is prolapsing into the anterior chamber. So once the vitreous which is prolapsing, you break it or cut it with the vitrector. The rest of the vitreous goes back into the posterior chamber and you can place your IOL. Core vitrectomy is removal of the central bulk of the vitreous. It's usually indicated in endophthalmitis. Subtotal and total vitrectomy. In these cases, the whole of the vitreous is removed. The manner in which you can perform a vitrectomy is of two types: open sky and 3-port. Open sky is when the vitreous is open to the AC, usually done during cataract extraction or during penetrating keratoplasty in phakic eye. 3-port vitrectomy is in a closed eye in which you insert 3 ports in the pars plana. One is the vitrector. Vitrector has a guillotine head which moves fast and it cuts the strands. Along with that, there is a suction. Then one you need for an infusion, that is named as cannula here, and then there is a light source to illuminate the posterior segment. So what are the indications of vitrectomy? There are 101 indications: endophthalmitis, tractional retinal detachment, proliferative retinopathies, long-standing vitreous hemorrhage, any complicated case of retinal detachment due to joint retinal tears or retinal dialysis, removal of intraocular foreign bodies or dropped nucleus or dropped IOLs, persistent large vitreous opacities when you are suspecting a tumor of the retina, persistent primary hyperplastic vitreous membranes. Then if there is a vitreomacular traction causing cystoid macular edema, macular hole, and epiretinal membrane peeling. So these are a few examples or indications of vitrectomy. So once you remove the vitreous, you have to substitute it with something in the posterior segment. Okay, so what are the features of an ideal vitreous substitute? An ideal vitreous substitute should have good surface tension. It should not leak out of the wounds. It should be optically clear, and it should be biologically inert. So the type of vitreous substitutes that you can use are sulfur hexafluoride, which are gases, perfluoropropane, and sometimes you can use air. Okay, the liquids that you can use are ringer lactate or balanced salt solution temporarily, perfluorocarbons, that is usually used to tamponade during a surgery, and then silicone oil is used following a vitrectomy, and it is left for around 4 to 6 weeks till the retina attaches back. So that's all for today. We will be joining back with the next class on retina. Thank you.